So what is the optimal strategy? And this is a topic that's been now around for roughly 12 years since the first publication on the strategy of expectant management with selective intervention, about 15 or 17 years since we actually started doing it. So it's not really a new concept, but the field is actually evolving quite rapidly. We've heard a lot about that today, biomarkers, imaging, all of it pertains to surveillance and how you do it. And a lot of this is in evolution. And I'll show some new data that just emphasizes the importance of not being complacent, that you do need to follow these people because some of them have problems. Most do not. So what's changed? Greater recognition of the overtreatment problem and wider acceptance. So the pendulum has swung, and I mean, this has just been a dramatic shift, really reaching its peak with the U.S. Preventive Services Task Force recommendation against screening due to mainly overtreatment. Better understanding of the nature of occult high-grade disease, and we've heard something about that this morning. 25 to 30% of low-grade cancer patients harbor higher-grade cancer, and identifying them earlier and understanding who those people are. The new definition of clinically insignificant disease beyond the STAMI 0.5 cc's of Gleason 6 or less. Better understanding of the flaws of PSA kinetics, which we and other people used for a long time as a trigger for intervention. It doesn't work as a trigger for intervention. And I'll just go into that, into why it's sensitive but not specific. Increasing data on multiparametric MRI, obviously. Modeling studies with sensitivity analyses around the expected potential increased mortality associated with surveillance compared to treatment that basically showed, even with wide boundaries of what mortality you might expect, the quality of life benefits are so substantial that it's really a very robust approach. Longer follow-up. So this is where it gets interesting. The criticism from the get-go has been these patients will die if you follow them long enough. And based on the Johansson data, which has recently been updated, that long-term, patients start to die of prostate cancer without treatment in the 20 to 25 year frame. So we've always been criticized, justifiably, that the cohorts aren't mature enough, but they're getting mature and there is longer follow-up. And then the role of 5-ARIs, the REDEEM trial that showed a benefit of dutasteride in men on surveillance. So there's a lot happening. You're all familiar with the task force summary, grade D recommendation. This leaves no place to hide. There's no grade E. Grade D is as bad as it gets. Basically, the recommendation is don't do it, period. High risk, et cetera, it doesn't matter, mainly overtreatment. And, the response to this has been very strenuous from some particular urology circles. But we can't hide our head in the sands. We have to start doing things differently. And there is a case to be made that active surveillance benefits patients not just by improving quality of life, by avoiding overtreatment, but actually saves lives. And the way this goes is, because of overtreatment, screening has been discarded by policymakers, at least in the United States, and it's had an influence all over the world. If we avoid overtreatment by surveillance, then the number needed to treat will fall, screening will be rehabilitated, it'll become acceptable again, the high-risk patients will once again have the benefit of early detection, and the mortality will go down. So that's really a compelling argument for a more conservative approach for the low-risk patients. So first of all, who is a candidate? And the well-known Epstein criteria, 1 to 2 positive cores, no core more than 50% involvement. We heard earlier he's still sticking with that, at least for now, versus low risk, which is Gleason 6 or less and PSA less than 10. So really this raised the question, what is the impact of volume? And should volume make a difference? And the key message is that for the vast majority of patients, the significance of volume, it doesn't confer a worse natural history by itself. What it does is it tells you the patient has a higher risk of harboring higher grade cancer. So that's, in our series, this is our data, the patients who had higher number of cores had more than a 2 times greater chance of harboring higher grade cancer. This is the Hopkins data, exactly the same thing. Down here, low risk versus very low risk, so that's Epstein criteria, approximately a 2-fold greater risk of being upgraded on subsequent biopsy. So the higher volume Gleason 6 is mainly significant because it identifies that patient being at risk for harboring higher grade cancer, and that's the one you want to find. So it doesn't mean you have to treat these guys. It does mean you have to watch them more carefully. This is just one recent study, also from Bal Carter's group, that compared in patients going on surveillance with a variety of pathology criteria. So Epstein, yes or no, multiple cores, 50 to 60% involvement, et cetera, and then a subset were eventually upgraded beyond Epstein or beyond Gleason 3+3, treated and had PSA failure, which is really what you want to avoid, and it basically didn't make a lot of difference what they had at the start. They all did very well with when they were eventually treated and followed. Of course, the chance of treatment is higher if they have higher grade cancer, higher volume cancer. So back to the question of who, is it only 3+3? So there's been great inflation, as we discussed earlier. The Gleason 7 of today is not the Gleason 7 of 10 prevalent. There's also a lot of artifact in this area. So I don't think the pathologists are still here, but the pathologists know that one of the major pitfalls in surveillance patients who often have very small amounts of cancer on the biopsy is that with the modification of the scoring system, all a biopsy needs to show is 1 microfocus of 4, and it's a 7. And you can get an artifact by tangential cutting of a Gleason 3 acinus, pardon me. If the lumen is missed on the biopsy core, the pathologist will see a nest of cells without a lumen, and that is one of the main criteria for higher grade cancer. And a dedicated pathologist will go back to the block, cut down further till he finds the lumen and says, that's a 3, not a 4. But not everyone does that, and the result is this phenomenal grade inflation to 2/3 of newly diagnosed cases in some places now being Gleason 7. So there's the artifact, 3 plus a little bit of 4 may be an artifact, or it may not have much biologic significance. There's 3 series in the literature. This one is our experience with Gleason 7 managed with surveillance. Gleason score not predictive of progression requiring treatment. Here is the UCSF experience. The yellow line is the Gleason 7 managed with surveillance. They actually did better than the Gleason 6 in terms of the likelihood of being treated. So, the Gleason scoring system is powerful, but there's a gray zone, and I think particularly in older patients, however you define that, maybe over age 65, not that old, a little bit of 4 should be considered at least possible candidate for surveillance, and here there may probably a role for MRI. The MRI negative patient with Gleason 3+4 probably has very small volume of tightly packed disease, probably going to do very well. And certainly the data supports that. So really the assignment was to discuss how it should be done. So these are the criteria. So there's the eligibility, there's the criteria for, or the trigger for intervention. This is the 8 or so prospective series in the literature. This now comprises more than 4,000 patients. The biggest series is the multidisciplinary group from Rotterdam with several first authors. I think Bull is one of them. So most people use upgrading. There's a lot of consistency about that, greater than 6. We've used predominant Gleason 4 as a trigger just because we don't want to overtreat, particularly in the older patient, the guy who's got a little bit of 4. PSA doubling time was used by a lot of groups. We don't use it anymore. In the PRIAS group, 20% of the patients treated in their last publication were treated for a short doubling time. And T-stage, which almost never happens, and a few groups use volume increase. Miami, this is Hopkins, this is Copenhagen. So again, I think this is going to result in overtreatment, but that is what it's in the literature, and more core involvement. So Hopkins, which does annual biopsies, treats everyone who has more than Epstein criteria, more than 2 positive cores. So one of the interesting questions in this field is, what is the origin of the upgrading? There's no question, most of it is sampling. So this is from our series. We have now about 1,000 patients on surveillance subjected to serial biopsies. And at the get-go, the upgrading rate is about 20% with the first confirmatory biopsy. So we know it's just sampling. You target the anterior and the anterolateral prostate. You are going to find higher grade cancer in 20%. But the interesting thing is that likelihood of upgrading increases over time, and the rate is about 1% per year. The best explanation for that increase is that this is approximating the likelihood of spontaneous grade progression, true biologic transformation of Gleason 3 to 4. And pathologists will tell you that it's rare to see a very small pure Gleason 4+4. What you see is either large, high volume, high-grade cancers, or you see a field of 3 with 4 starting to emerge in it. And our view is what's happening is you get accumulation of 3 with possibly some of these pre-histologic genetic changes. And at the rate of about 1% per year, it converts and starts to become a 3+4, and then perhaps predominant 4. So, that's an important figure because it means the patient's at relatively low risk, but not zero risk. You have to follow them. You need some effective way to reevaluate what's going on in the prostate. And it's about 10% at 10 years who are going to have significant grade progression. The follow-up, we and the PRIAS group, PSA every 3 months for 2 years, then every 6 months. We don't do DRE anymore that often. Biopsy within a year, and then approximately every 3 to 5 years, depending on age, comorbidity, et cetera. Stop at age 80. A couple of other groups is called the Canary collaboration, kind of similar, every 18 months and every 1 to 3 years. And then there's the Carter group at Hopkins, annual biopsy. They have published that erectile dysfunction rate is increased after 3 biopsies. That's well known. They are doing this not because they think it's necessary, but they're doing it for scientific reasons, which is very legitimate. They want to really nail down what is the likelihood of progression, but it is clearly not necessary to do that. And frankly, how do you get these guys continuing to come back for transrectal biopsies after the 3rd, 4th, 5th, et cetera? Not easy. So this is our updated data. It's now about 840 patients. We have follow-up beyond 20 years in a handful, and beyond 15 years in a significant number. About 1/3 or 40% have had intervention. So this is the first area where it's clear going forward we can do better. That graph should not look like this. It should be a sharp fall where you identify the bad actors right at the beginning, and then you find the 1% over time who have biologic progression. So this is one area where there's clearly room for improvement. Having said that, it means even out to 15 or more years, more than half of patients are avoiding treatment altogether. Here's the PRIAS, almost exactly the same data, which is remarkable considering it's in another continent. It's, considering all the selection factors and so on, and treatment trigger factors, they have treated almost exactly the same proportion at the same period of time. And overall survival, median age in our cohort is about 68 at diagnosis, and the patients start to die if you follow them long enough, and so roughly half of the patients have died. mostly of other causes. I mean, half of them who are the long-term patients have died. And here's the prostate cancer mortality. Now, this is where it actually gets interesting, because in our second analysis, which we published about 4 years ago, we had 453 patients, 5 deaths. They were all early. There were no patients who looked like they sort of progressed over time and died of prostate cancer and would have been cured if they'd been treated earlier. They were all early failures. But now we've got late failures. So there's 14 deaths out of 843. So the overall mortality rate from cancer is about 2%. But there's about 6 deaths in guys who probably were curable down in here and were followed for 10 or 15 years and eventually started to die of prostate cancer. And you know, this slope is a little disconcerting. This is about 15% of the patients who lived more than 15 years have died of prostate cancer. So the message is, it's still an unlikely event, but these patients need to be followed lifelong, and there is still some room for improvement to find those bad actors earlier on than we have done. Again, all our efforts are going to result in a handful of fewer deaths. But even one unnecessary death, if it's preventable in a reasonable way, is compelling. And then the PSA failure rate, so these are the roughly 35% of patients who were treated and then went on to have PSA failure. So the surgery patients do better than the radiation patients, probably selection bias, or maybe it's better treatment. We won't get into that. But about 20% PSA failure out to 10 or 12 years. And that's, again, a third of the cohort. So it's about 6% or 7% of the overall cohort eventually go on to PSA failure, which I think is pretty acceptable. And then the mortality rate stratified by cause. So this is called the cumulative hazard ratio for death. And in our previous analysis, the ratio of other cause mortality to prostate cancer mortality was 20 to 1. 20 times greater chance of dying of of other causes. And the question was, what would happen with longer follow-up? And now it's 10 to 1. So actually the ratio, the likelihood of dying of prostate cancer compared to other causes has increased with longer follow-up. It's the same story. We've got some room for improvement. Doesn't say that the approach is not valid. Again, another recent publication from Sloan Kettering showing essentially that with this strategy of surveillance, delayed treatment, you still have favorable pathology. So this is their surveillance cohort, the subset who were treated, I think it's about 45 patients, and the majority there were only 3 patients, 6% had positive nodes, 1% positive surgical margins. Overall, the message is, the vast majority of patients who look like the bad actors and are treated still do pretty well. So, but there's room for improvement. So how can we improve? The challenges are to risk stratify accurately, to find change when it occurs, to reduce the burden of the biopsy that we've been talking about. Patients don't like it. The biopsy is a problem. It doesn't exclude significant cancer. Overdiagnosis, urosepsis rate is 4% in our province. It's quadrupled in the last decade due to quinolone resistance. Men don't like it. PSA is unreliable for monitoring patients. It's too labile. The DRE really doesn't add much. And so what's been learned over the last 5 years or so is that although we do a great job of biopsying the peripheral zone with the initial diagnostic biopsy, the anterior prostate and the lateral horn and also the apex tends to get missed. There's one series from Hopkins, 100% of the patients on surveillance who eventually had surgery for a tumor greater than 1 centimeter had anterior cancers. All of them had anterior cancers. So that is where the occult lesions tend to be in patients who have had decent peripheral zone biopsies. And so this is the emerging role without a doubt of MRI, and we heard something about this earlier from Claire's great talk, that a role it may replace biopsies, the initial screening modality, but certainly in this setting of the patient on surveillance. And this is the one, I think, most impressive recent study on this topic from Sloan Kettering, the performance of MRI in this surveillance population, about 400 patients, the negative predictive value, which is really the important statistic. If it's negative, how confident can you be that there is no clinically significant cancer? 97%. That is an amazing figure. Now, it's 1 centimeter, it needs to be validated. But if you can say to the patient, your MRI is negative, you have a 3% chance of having clinically significant cancer, that's so much better than anything we do so far. And also the positive predictive value also relatively high in the 90 to 95% range for a PRIAS 5 out of 5 lesion. And then one of the emerging questions is, how do you incorporate the MRI? How do you do the biopsy? We have this Artemis device, partly developed locally, image-guided. It imports the MRI target, and then using a gantry, it guides the needle to go right through the target. So this has obvious advantages over cognitive co-registration, where in your mind you say, okay, it's in the left peripheral zone laterally, and you try and target that using ultrasound. It prolongs the procedure, adds to the cost. I think there's still a question as to what its role will be, but some of the data that's come out, this shows targeted versus systematic biopsy, 3 times greater yield of significant cancer. 3 minutes? Perfect. Okay. So, and again, this is the kind of thing that you get where, you really see the biopsy going right through the target. And then this just an example of how good the MRI is at finding these clinically significant cancers. And then this study, which compared targeted to systematic biopsies, percent positive cores on the bottom, maximum core length here. You see you're getting more core length and more core involvement very significantly by doing targeted biopsies. It certainly makes sense. This is a study we're in the middle of, a prospective randomized study in Ontario in patients on surveillance, randomized between regular trust-guided biopsy and MRI with targeted biopsy in the patients who have a target. And the idea, with a bit of luck, if it pans out, is that MRI will actually replace the systematic biopsy, and they'll only get a targeted biopsy if the target's positive. The MRI for monitoring these patients also probably has a role, and this is a guy with minimal disease, T1A after a TERP, followed from 2009. He's got a very nonspecific abnormality there, and then boom, 2 years later, this thing explodes on MRI. You would never, his PSA was stable. You would never really appreciate this without this kind of imaging. So this is early days, but it certainly has an appealing role. Biomarkers, PCA3 doesn't work. 4 of 6 studies shows it of no value in finding higher grade cancer. Then it's a good test probably for low grade cancer. But, and this is the TMPRSS2 ERG combined with PCA3. This is why I asked about the ROC curves earlier, because I don't know what you do with this. It increases the area under the curve marginally by adding TMPRSS2 ERG and PCA3, but does it really give you a definite enough answer? To my mind, the MRI is much more powerful. But this field is on fire, and there's a score of companies that are trying to develop either SNP or tissue-based or urinary-based assays to try and get a handle on this. And something is going to come out of this. So finally, the message. If you tell someone they're on fire, they run for a fire extinguisher. Cancer drives treatment. We need to communicate a different message, as we discussed earlier. This is some data from Capture showing the acceptance of surveillance by urologists, mainly in California. So this is the likelihood that patients with low-grade cancer were going to be managed by active surveillance. Half of the patients offered surveillance were managed by 3% of urologists. This is American. We've done much better in Canada, but clearly there's still sort of some convincing to do about the importance of this. I don't think it's surveillance versus focal therapy. They're complementary. Focal probably has a role, although it's debatable, but the large volume 6 or the Gleason 3+4 that's unilateral, I'm not sure surgery or radiation is required for these patients, and certainly radical treatment is not going away. So finally, I would say, our approach is to offer surveillance to all Gleason 6, which is acceptable to most patients. PSA kinetics is a guide. I didn't get into this, but it lacks specificity. In our series, half of the stable patients had a false PSA trigger for intervention, would have resulted in overtreatment in many, many patients. Confirmatory biopsy is critical, repeat every 3 to 5 years. MRI, we do selectively just because we don't have the resources to do it in everyone, but I think that maybe is the way the field is going, and we treat if there's a significant Gleason 4 or PRIAS 5 on the MRI, which has over a 95% positive predictive value for significant cancer. Where is this going? As we've heard, there's an increasing role for MRI in screening. That will result in fewer clinically insignificant cancers. The cancer diagnosis may change, although not according to Jonathan Epstein and the majority of the people in the room. In favorable risk disease, we need better imaging and biomarkers, but I think a caveat is it's got to be affordable, available, reproducible. The OncoDX test, which has been promoted, costs $4,000 for a score, and I'm not sure that's really gonna work out. I think the goal is a number needed to treat of 1. We find the people who are gonna die without treatment, we treat them, and we're confident enough in our assessment that we can manage the rest conservatively. And I just want to conclude with a brief ad for our fellowship program. We would love to have your young trainees come to train in urologic oncology in Toronto, and they can contact me if they're interested. Thank you very much.
Thank you very much. Do we have any questions, briefly? Mr. Durkin.
Thanks very much. Garrett Durkin from Galway in Ireland. Thank you for a great talk and for doing this work that I think has changed the practice of a lot of urologists, certainly in these islands. I have a fairly significant cohort of men who are on active surveillance, and we pretty much follow your protocol. But I've been burnt once or twice. This comes back to the Journal of Anecdotal Medicine. I'm concerned about putting young men in their 40s on active surveillance. You showed some data showing that after 15 years, there were a group that could have been saved that died of prostate cancer. And I've no issue with the over 60s, but maybe could you just comment on the younger group?
So that's a great question. And I think that inference that you drew is the wrong one. We know from the autopsy data, 30% of their men in the Sacker series in their 30s had microfocal prostate cancer. About 45% of men in their 40s. So the prevalence of microfocal prostate cancer in men in that age group is high, and we find it sometimes. So I don't think being young is a contraindication to surveillance. Having said that, some of these guys, a minority, have an abnormal prostate, and if the prostate is extensively infiltrated by Gleason pattern 3, I think what you're saying is reasonable. Extensive disease in a young guy is something to worry about, given all the limitations of our evaluation of that. But the majority, what they have in that age group is 1 or 2 microfoci, and I think those patients, by and large, have the same latent pseudo-cancer as the older patients and are not really at risk. The inference from the death rate is we can do it better. It's not that surveillance should be abandoned, even in those younger patients, at least in my opinion.